Hi everyone. This week we're going to be looking at the processes of dying. But what does this mean? Are dying and death the same things? How might they be different? What do we need to know and understand so that we realize our opportunities to help patients leading up to and during their actual death experience? As we consider these questions and topics, we're going to be looking at them from both a personal and professional perspective. I encourage you to be thinking about any previous deaths that you have experienced, especially if you were able to be there in the days or hours leading up to the death. Consider your own experiences in these moments, but then also be open to how others' experiences may be very different. Every life and every death is unique. But let's talk about some common themes that we need to understand. Even though we often use these words synonymously, there really is a difference between the process of dying and the process of death. The dying process involves many aspects of the person's thoughts and emotions on top of just the physical changes they may be experiencing. How are they feeling about the death? How are they adjusting to any changes that are occurring or will be in the future? What might they be doing to cope, whether that means avoiding it or embracing it or somewhere in between? These types of things all relate to the process of dying. It's a journey over time, at least for most people. The process of death refers to what happens to the body after death. A few weeks ago, when we looked at biological and physiological changes that occur once someone dies, those are the processes of death itself. Cessation of heartbeat and respirations, cellular death, rigor mortis when the muscles stiffen, those types of things. Actively dying is a term that refers to what is happening in the body as it is naturally shutting down. This usually refers to the last days or hours of someone's life, and we'll be examining this in today's lecture as well. We recently talked about dying well, about how this notion of a good death occurs when one feels as though they have some control over how and when they die. If they want to be with family or alone. If they want to resolve any unfinished business or repair estranged relationships. If they want to die peacefully in their sleep, or maybe doing some activity they love. This notion of dying well is seen as an ideal, although it's not always possible. Social death is another important term that you want to understand. This has to do with the natural distancing that tends to occur when people are dying. For many reasons, whether it's the patient's decline, the friend or family's discomfort in not knowing what to do or say, or any other reason, people tend to pull away or isolate the person who is dying. This may be the patient themselves who begins to withdraw, or it might be the other family members or friends who slowly begin to distance themselves. This can leave both sides feeling awkward, uncomfortable, and sad, and yet it often goes unaddressed or doesn't get addressed in time, and the person dies feeling very alone. One important thing to remember about dying people is that they're still a living human being. They're not dead yet. This often gets lost under the pressure of dying. They still have needs and desires, and they may be very different than what the rest of us are needing. Coping refers to our efforts to manage changes in our environment. How do we adjust to these changes? Is it easy? Hard? Scary? Overwhelming? This is a perceptual concept. Each person determines what is taxing or demanding, and each person assesses his or her means of coping. Oftentimes, efforts to manage stressors are coping, even if they don't appear to be too helpful. Coping is a skill, and it can be learned and improved when it's seen as important. Dying people may be concerned with issues that you might not think are important, but they are important to the dying person. Sensitive caregiving allows that person to express those concerns. Here we see three different focuses for coping. Three different ways that we tend to manage life's stressors or changes or adjustments that come our way. At the top, we see appraisal-focused coping. This is where someone finds that silver lining, where they're able to find the positive even in the midst of all the darkness or fear. Some people are naturally a glass half full type of person, and this comes naturally to them. This allows them to focus on other positive, fulfilling things even when their own health is declining. Other people are problem-focused. This doesn't mean they focus on the bad necessarily, rather it just means that they like to identify what the problem is and then figure out a way to address it. What are you going to actually do about it? Will you start doing some things, stop doing others, adjust your approach? How can you attack that problem? Finally, some people use emotion-focused coping. Here, they're aware of how they're feeling and how they're reacting to the problem, and someone may be focused on trying to maintain their composure or find that balance or even just feel how they feel in that moment. They're looking more at their emotional response and reactions. It helps us to understand which approach that we tend to use when we're faced with a crisis. Even if you haven't faced your own death, and most people taking this class haven't yet, obviously, but how have you handled past struggles or obstacles? Which of these tends to be your natural inclination? At the same time, we also want to be observing and talking with our patients to determine which coping style they tend to gravitate toward. Once we know this, we can adjust our own interactions to try to support them in a way that will resonate more personally with them. That doesn't always mean doing the same thing they do or shed light on a new perspective. It really all depends on your patient and what they're really needing from you. Remember, we don't want to be there to just give advice. Instead, most of the time it's better if we're able to just be comforting them and listening and just be. Stressors can be many things. Happy changes as well as unexpected, difficult changes. Perception of stress is up to that individual person. Some things present a variety of possibilities in coping. Others do not. People vary in their ability to learn new coping skills. Other people in the support network vary in their ability to help as well. Sometimes the dying person is affected by the vulnerability of other family members, and then he or she can't really attend to their own issues that they have to deal with. Other dying people can't let go of the independence they have traditionally displayed in order to let other people help and care for them. Family styles of interaction and communication also affect these processes. An effective caregiver is sensitive to all these aspects of a person's feelings and needs. This all relates to how people cope with the impending loss. Just as we looked at determinants of the grief response early on in class, we need to recognize now that these same types of factors that impact the death experience from the patient's perspective themselves. Let's consider the nature of the dying trajectory. Was there an accident that occurred suddenly and the person is gone? Did they become ill, but only for a short time period before dying? Were they suffering from an ongoing chronic condition that lasted for several months or even years? Certainly, these are all different experiences and thus will influence the patient's coping style and coping abilities in different ways. Next, we look at how that journey or process has been. Were they here one minute, gone the next? Have they been on a roller coaster ride with many ups and downs along the way? Did they go into remission and stay well, or then relapse and become seriously ill once again? Have they had a slow, steady decline? These physical changes bring many emotional, social, and spiritual hurdles as well, and that all impacts the dying experience for the patient and for the family. Finally, we need to look at how people are communicating about the dying. Is the family open and thus sharing freely about their hopes, fears, and concerns? Or do they all keep to themselves and not talk about what's going on, potentially even with the patient? Every person and every family operates a bit differently, and these interpersonal dynamics can make a big impact on how the death is handled. This leads us to consider just how aware the patient is of what's actually happening. Since every situation is different, let's consider some of the more common trends we see in healthcare. In some cases, the person doesn't know that he or she is dying. This is referred to as closed awareness. If others know, however, there is usually a certain stiltedness in communication which subtly conveys some changes in the outcome, however. With suspected awareness, the dying person may suspect that he or she has not been given all the information available, and so they may not trust their caregivers or their healthcare providers if they won't share what they know. Sometimes everybody involved does know the prognosis of death, but there's an unspoken unwillingness to talk about these things. This represents the mutual pretense context, and unfortunately, this requires a lot of vigilance. Otherwise, someone lets something slip, and this energy could be better used to help the person with the task that he or she is facing. Finally, open awareness means that the dying person, as well as caregivers and family, are all aware and willing to discuss the fact of death. It may not be actively discussed much, but there is willingness to discuss it when necessary. Each of these contexts holds some benefits as well as some difficulties, but in general, open awareness allows for honesty, and it offers each person involved the opportunity to express their needs and feelings. Regardless of the family's style of communication and coping, the patient is often aware that something is wrong or something feels different. They can often sense this and may even deny potential symptoms at first. Think about it. Think about all the times we hear of people saying that they knew there was something wrong, but they put off going to the doctor because they just weren't ready to deal with it, or they didn't want to get bad news, or they knew they couldn't afford treatment, or they were scared of what the doctor would say. Once they do know what's wrong, a part of their identity and self-image begins to change. Now they're no longer just a grandparent or a parent or a teacher or a nurse. Now they're also a cancer patient, or an uncontrolled diabetic, or someone with Alzheimer's disease. Not only do they look at themselves differently, but they often worry that others will look at them differently as well. This is where anticipatory grief sets in. Remember, we talked about this early on in the semester, and this is when you're grieving a loss that hasn't happened yet, but you know it's coming up. The patient begins this grieving process themselves, even if they haven't told anyone else yet about their illness or terminal condition. It's not uncommon for that magical thinking to reappear here. Just as we saw magical thinking with children wanting to understand or control what's happening, we see it with patients who sense their death is impending as well. They may think that they can subtly change the outcome or control what happens, even though they may not really be able to. Regardless, these are normal experiences. They aren't going crazy or losing their mind. They're simply grieving, and they're grappling with this knowledge that their health status is dramatically changing. This brings us back to Elizabeth Kubler-Ross's stages of dying. We went through each of these earlier in a more generalized conversation about what it means to die. Here, though, I'd like for us to look at it again in a slightly different and more personal way. If you knew that you had a specific period of time left to live, what might you do? Even if you're terminally ill or you've suffered a catastrophic acute injury, are there things you'd like to continue doing? Ways you'd like to continue living, in spite of the fact that you know you're dying. Maybe you want to visit an old friend, make amends for past wrongs, take a vacation, or complete other items on your bucket list. And yet, how do you find that balance with the chores and routines of daily living? The dishes still need to be done, the laundry folded, meals made, kids cared for, the dog walked, and so forth. How does this dying process and the grieving process impact these very real aspects of living that still need to be taken care of? As we look back over these stages, remember that anger is a secondary emotion. Try to find out what's underlying it, as anger often gets taken out on the caregiver, even if it has nothing to do with him or her. Are they really afraid? Are they overwhelmed? Are they in a lot of pain? What's the stem of that anger? Also, know that there are different types and causes of depression. On one hand, your patient may be experiencing a reactive depression in which he or she is very sad and depressed after getting the diagnosis. Others may experience a preparatory depression, which is how they're reacting to the losses anticipated with their impending death. Even though there's a lot of discussion and even disagreement surrounding Kubler-Ross's stages of dying, her first book, entitled On Death and Dying, did contribute some valuable insight into what is necessary to offer sensitive care for the dying person. She reminds us to refocus on the patient as a human being. These people are still alive. Treat them that way. Allow them to express their unfinished business with others. We also want to include the patient in our dialogue to learn from that person the strengths and weaknesses of our management of their illness and interests. This can aid family members as well as caregivers. None of us can be effective unless we seek to serve and identify with them what those needs really are. Finally, she suggests we should ask those who are coping with dying to be our teacher so that we may learn more about the final stages of life with all its anxieties, fears, and hopes. Through these interactions, we can learn more about ourselves and about being human, taking down those walls and defenses by which we feel secure but alienated from others as well as our own needs. In other words, allow the dying to teach us. In a story about a man who was given a prognosis of just 2 years to live, he stated, "It forced upon me the necessity of making calculated, determined decisions. I had to assume I had only so many years and so much energy left, so what would I do with that?" So I turn that question to you. If you had just 2 years left to live, what would you do? What if it were just 1 year? Or even 6 months? I'd like each of you to push pause and make a list of what you'd need to do, what you'd like to do, and then how would you prioritize those items that you've listed down. Take some time to really think about this in a meaningful way, and when you're ready to continue, go ahead and push play. Coping involves more than an automatic or defensive reaction. Defensiveness is generally negative, and it doesn't channel much energy into creatively solving problems. Coping is an active process, activating a positive orientation that seeks to solve problems or successfully adapt to new challenges. So coping involves tasks. Tasks may be undertaken as we are prepared and in a number of ways. The more choice we perceive ourselves having, the more empowered and less victimized we feel. Tasks first and foremost involve the person's concerns, even more than needs which may be met by others when necessary. Tasks are open to the dying person to manage as he or she feels important. This concept also puts the dying person at the center of activities and expects caregivers to focus on these things, rather than their own perception of what the dying person might need. There are 4 different types of tasks that the dying person needs to explore as they cope with their impending death. These are physical, psychological, social, and spiritual tasks, and we'll take a few minutes to look at each. Obviously, most types of conditions that result in death involve a physical component. If there wasn't something physically wrong or physically changing, the person probably would not be dying. We need to remember that basic physical needs must be met in order to provide comfort, and these may change a little bit at the very end. For example, we know that someone cannot survive without food, water, the ability to breathe, and so forth. As someone approaches death, though, the body naturally adjusts, and they need different amounts of these things. But if we ignore them completely, there's no way the patient will be comfortable. And pain is a big part of this. There are so many different types of things that we can do to help address pain, and we need to remember that our patients define what their pain level really is. We want to keep people as comfortable as they want to be as they die. Some people want no pain, and thus they prefer pain medications, massage, music, or other remedies. Yet others want to fully embrace their pain, and they see suffering as a part of life, as part of earning what comes next according to their belief system. If they don't want to talk about it, or they don't want pain medications, that's their choice. We can't force them to do anything they don't want to do, even if it makes it harder for us to watch them suffer. Psychologically, dying patients are also concerned about their security, autonomy, and the richness of the experience. Even facing a death, a person can benefit from the assurance of safety, that others will remain present when they're most needed, that they may retain as much control over their process as possible. And the richness of the experience may include such small things as comfort in managing one's appearance, enjoying their favorite foods, or music, or the right to control visitors who may be a bit troublesome. Most people need some time to adjust to what's happening or what's impending. They may need to ask questions, to gather information, or just have some quiet time to process all that's going on. And remember, if they're in pain, these important tasks cannot happen. Pain overrides everything, so try to manage it as best you're able according to their wishes. Socially, the person is trying to manage attachments to others and society itself. With interpersonal attachments, there's often increased focus on smaller things, things to do with their internal consciousness, rather than external issues. There are new priorities as one lets go of responsibilities for earning money, paying bills, and so forth. The patient may need to engage in some tasks on their own behalf, for their own benefit. This may include control over medication, or deciding whether or not to continue treatments. Others may want to insist on the person still fighting, when the person merely wants to enjoy the rest of his or her life as is. The person may also feel the need to instruct others in matters of great concern to them, whether the other one is ready to face that person's death or not. It needs to be respected. In other cases, the caregivers may be busy about final arrangements when the person needs their presence in order to feel safe. There may also be tasks in relation to others who are involved. This involves the concerns of caregivers and family members who may be confused about what will happen to themselves or the assets the person has managed up to now. Finally, social groups have their own rituals concerning the dying person, which affects the viability of the group. Also, there are examples or responsibilities to society that continue even as the person is dying. Taxes, bills being paid, managing support systems, and their need for information, and so forth. Each person determines what their spirituality demands. There are common themes, however. We'll look at meaningfulness, connectedness, and transcendence. Meaningfulness. The task of formulating meaning from one's life as well as from one's suffering. What was the purpose? Did I manage my life in a fruitful way that leaves some legacy? Did I make a difference in the lives of my family or others? Connectedness. A death process can untether one's connection to others, to self, and to the divine. There may be a strong need to reconnect in a more authentic way. Transcendence. The source of meaning that goes beyond the ordinary. This particularly concerns hope. For many people, hope is a side effect of feeling part of a religious tradition, with all it implies about an afterlife. Even non-observant people will often try to find meaning for their lives within the reality of the universe which they do accept. Depending upon one's belief system, the concerns vary. Is it about my own ultimate destination, or my effect on my relatives as I leave them? The task for others is to support this process, whether you agree with the belief system entirely or not. What tasks a patient needs to address first, or in what order, or at the same time, really all depends on what's happening in their life. Where are they at in the disease process, or the decline following a serious injury? Depending upon what's going on, they may only be able to consider one thing at a time, or they may be trying to do all this grief work and dying work at once. Let's consider some of these different contexts and how they impact the tasks related to dying. The pre-diagnostic phase illustrates that some people need denial when they're first feeling different symptoms. They're having to gear up, if you will, for this difficult diagnosis that's coming. Others seek advice or use alternative methods to deal with something ominous. The task is managing anxiety or risk. In the acute phase, one is trying to understand the disease, to consider possibilities, manage treatment, develop coping, and develop strategies to deal with disease-related issues, while also expressing feelings about the future or the past. The chronic phase is one where the focus is on managing symptoms or treatment, managing stress, accessing social support, and trying to normalize life in the face of illness. Oftentimes they're dealing with finances, even with redefining relationships with others. This chronic phase also includes trying to find meaning in suffering or mortality. The recovery phase is an interesting challenge. When there's a remission, the crisis has still changed the person. Simply having dodged death leaves us changed forever. There are often side effects from illness or accident, worries about recurrence, financial weights, redefined relationships with others and self. The person may also relapse and once again be in the throes of serious illness. Ultimately, the terminal phase brings a new set of tasks arising from the illness and impending death. They're concerned about the nature of treatment, concerns for caregivers and survivors, changing symptoms or increased distress, and how to say goodbye. So think about all these different phases or steps in the progression of many illnesses, and then recognize how challenging it can be to try to be processing and coping physically, psychologically, socially, and spiritually. It's a lot for anyone to handle, let alone someone who is very sick and dying. With that, let's take a break for now. When you come back, we'll talk about what we might see or expect to see in our patients as they're approaching death. For many of you who want to know the signs and symptoms, or are trying to learn how to better estimate the amount of time a person has left, you'll find this upcoming information very useful. In the meantime, of course, if you have any questions over what we've just covered, be sure to let me know.